For joining us this morning. I have the distinct pleasure of introducing Dr. Crista Johnson, who is going to present on advancing maternal health equity in refugee communities. And just to tell you a little bit about Dr. Johnson, she is an obstetrician gynecologist at a large health network, Valleywise Health in Arizona. She is also the founding director of Refugee Women's Health Clinic there at Valleywise. And she also wears hats at ASU as well. She's a clinical research affiliate with the Southwest Interdisciplinary Research Center. In that role, she serves as the director in the Office of Refugee Health. And she's also a research associate professor in the School of Social Work at Watts College of Public Service and Community Solutions. Her current research focuses on investigating strategies to advance sexual and reproductive health equity for newly arriving refugee women, particularly those that have undergone female genital mutilation or cutting, and also those who have experienced sexual or gender-based violence. Her aim is really to improve healthcare access and utilization for these very vulnerable populations. And she's going to have a really amazing story to share with us over the next hour. So please join me in welcoming Dr. Crista Johnson.
Thank you so much, Dr. Wisner. It truly is an honor to present to you all today and to be a part of the second annual Maternal Child Health Conference. It's truly amazing to be part of this dynamic team. I am going to share some of my work and experience advancing maternal health equity in refugee communities, focusing on local solutions for global challenges. And to start off, I just want to present a couple of disclosures. One, I'm a consultant with Synexus, but it's completely unrelated to the content of this presentation today. But most importantly, I want to acknowledge, first and foremost, my own positionality and intersectional identities and lived experience as a woman of color and an OBGYN physician engaged in this work throughout my entire career that really has anchored me in my advocacy and work advancing maternal health equity, reproductive gender, sexual health equity for minoritized communities. And so over this next hour, I'm going to first explain the global refugee crisis with special attention to the vulnerabilities faced by refugee women and the challenges we as providers face in delivering high quality care. Then we're going to describe a patient-centered medical home model that really integrates a team-based approach to care delivery that engenders trust with the refugee community and addresses the myriad social determinants of health. And finally, I'll identify best practice strategies in the provision of linguistically inclusive and culturally informed care that optimizes reproductive outcomes and promotes health and wellness for refugee women. So let's first start with some of the global challenges. We're in the midst of two major challenges: a global refugee crisis, which is unprecedented in the history of this planet. We have now well over 84 million people forcibly displaced, 26.6 million of whom are refugees, another 48 million are internally displaced individuals, and over 4 million asylum seekers. At the same time, over the last couple of years, we've been immersed in this global COVID-19 pandemic crisis, and we've seen well over 6 million deaths around the world. Even in the United States, we're approaching the 1 million mark, sadly. And so what does this mean for refugee populations who have been forcibly displaced? Well, let's first define who is a refugee. In 1980, Congress codified the Refugee Act, which designates a refugee as a person who is outside their home country and unable or unwilling to return due to persecution or a well-founded fear of persecution based on race, religion, nationality, membership in a social group, or political opinion. And so when we think about how do we identify refugees and designations based on gender and sex, there's often confusion over who is a woman at risk. There's inconsistency in the criteria for resettlement. Often staff lack adequate training and disregard rape and sexual abuse as sufficient grounds for resettlement. There's also a culture of distrust of refugee stories. and a disbelief of the extent of abuses women and girls face. They often lack access to resettlement opportunities, education, and experience poor quality physical health, social support, and legal protections. And as we have seen, especially in the last several years, slow response time among resettlement countries where refugees often live in protracted, unsafe circumstances for decades before they can resettle to countries such as the US. And when we think about maternal health in this global refugee crisis, it is especially dire, and it exposes so many vulnerabilities because we see humanitarian emergencies exacerbate violence and increase women's vulnerabilities and risk and other health inequities. We have seen the literature is replete with evidence of the lack of access to safe maternity care, delayed services, and even when services are rendered, it's often inadequate. And we know that 60% of preventable maternal deaths occur in humanitarian crises. And we see there's been an increase in cesarean sections, stillbirths, and other obstetric morbidity. And of course, we cannot ignore the profound mental health impact in terms of antenatal and postnatal depression, anxiety, and post-traumatic stress. And then, of course, violence against women remains pervasive. A study that has just been released by the World Health Organization last year shows that now nearly almost 30 years since the original UN General Assembly declared a global framework to eliminate violence against women, we still see that 1 in 3 women still experience physical or sexual violence, mostly by an intimate partner. There are other categories of gender-based violence, including sexual, physical, and psychological and emotional abuse, including child abuse, sexual harassment, child marriage, domestic violence, cultural practices such as female genital mutilation and cutting, and of course, trafficking in persons. And so immediately post-resettlement, there can be immediate protections where we can remove women and children from this abusive, exploitive situations, remove them from the hostile environment that they have been in, and hopefully aim to prevent future acts of violence and rape and kidnapping and forced marriage, etc. However, even upon resettlement in countries such as the United States, new vulnerabilities emerge, namely health concerns, the challenges for women as now heads of households supporting dependent children and experiencing disrupted family ties and social isolation, and often women being illiterate, not only in English, but in their native language because of limited educational opportunities that they've been afforded. And then there are also emerging challenges accessing and navigating healthcare. Often getting a timely mental health evaluation may not occur, nor may it be trauma informed. Women and families often lack socio-emotional support and are definitely exposed to racism, discrimination, and bias, experience challenges with literacy and language training, and often are relegated to low-skilled jobs with low salaries and often lack childcare. And so, as you can see, these emerging challenges result in ongoing concerns regarding women attaining economic self-sufficiency and supporting their health and well-being. And we see this very pervasively in terms of the impact of migration on preterm birth. This study was conducted in Canada, and you can see when you look at risk factors for very preterm birth, between 22 and 31 weeks gestation versus moderate preterm birth, we clearly see that when you look at all migrants versus primary migrants, meaning those who arrive in countries in the West as their first stop of destination, versus those who are secondary migrants. These are migrants who often spend time in protracted circumstances in refugee camps or other host nations before they can arrive in their final host destination. We clearly see in this population that these refugees have the highest risk of very preterm birth and moderate preterm birth, which really speaks to the vulnerabilities of long exposure to chronic stress in these tenuous circumstances. We also see that among migrants in Europe, Australia, and Canada, this was a study examining nearly 500,000 immigrants giving birth, that there is severe maternal morbidity with immigration, of which African women were demonstrated to have the highest risk of severe maternal morbidity, with severe preeclampsia being most common across all groups, and uterine rupture being most common among African women. We also see that destination also matters, in that when studies compared native-born women to African, Latin American, and Caribbean migrants, they were found to have higher odds of low birth weight in Europe, but not in the United States. And South Central Asian women were at higher odds of low birth weight on both continents. And this really speaks to geographic proximity in terms of one's geospatial relationships and proximity to social networks and resources and proximity to one's country of origin. What we also see is that because of the COVID-19 pandemic, there have been enormous consequences globally to the health and human rights of women and girls. And we see that projections over the next 10 years, that these are profoundly impacted in terms of women's and girls' health, in terms of increased risk of gender-based violence, child marriage, exposure to female genital mutilation and cutting, unintended pregnancy, and overall disruption in access to needed programs and services, safe spaces for care and support. There is profound fear, not just lack of PPE, but also we see globally the lack of access to vaccines, and of course, decreased service use.
Crista, I'm sorry to interrupt. Your sound shifted and it's a little muffled. I don't know if the mic just got changed.
Okay. Can you hear me clearly now?
It's still a little muffled, and we might just need to go with it, but I wanted you to be aware.
Okay. Let me see if I might be able to put in my headphones. If this might make a difference. Let's see if I can. One second. Can you hear me now? Is this clearer?
That's much better. Thank you.
Okay, great. Thank you so much for pointing that out. So I want to just briefly touch upon the current crisis in Ukraine. We now know that there are over 4.1 million Ukrainians who have been displaced due to the invasion of Russia, 90% of whom are women and children. We also know that there are over 200,000 non-Ukrainians who have left, and over 6.5 million who are internally displaced. And of course, they have fled to surrounding countries in Europe, and we have seen an overwhelming response globally to welcoming refugees. The Biden administration here in the United States has projected that they're willing to accept up to 100,000 new arrivals from Ukraine. But we also have to call attention to the crisis in this humanitarian circumstance that has risen with racism that has reared its head. In terms of the violence and racism among those who have tried to flee, but were Africans, Asians, Arabs, who have had enormous challenges in terms of experiencing violence, being exposed to sub-freezing temperatures, walking instead of being able to be allowed on trains and other transport. And clearly, we also see reckoning with how the media even portrayed coverage of the crisis in Ukraine. And even what we see in the United States back in August, we witnessed globally the evacuation from Afghanistan. And here we were providing a welcoming safe haven for over 84,000 Afghan citizens who were displaced due to the conflict there. But within a month of us welcoming Afghan arrivals, we also see what was happening at the US border in Texas for Haitian migrants, unfortunately, with this gentleman, Murad Joseph, who was bringing food across the border to an encampment in Texas. And this really triggered messages of slavery with being chased down on horseback And unfortunately, he was one of 18,000 that have been expelled from the United States and sent back to Haiti. And so we see that there is the pervasiveness of the impact of racism on migrant communities. And I'm going to show you the layers of an onion that really unpacks how this manifests and how this can manifest as chronic toxic stress across one's life course. So we see at the very core one's individual health in terms of access to care, acculturation, language and communication barriers, literacy challenges, behavioral health, morbidity, and one's safety and security. But when we look at that larger onion in terms of the interpersonal and family factors that can influence one's individual health, you can see family separation, loss of social networks, stigmatizing interactions between patient and providers, social stigma and myths and taboos about health services and cultural mistrust, experiences of bias and microaggressions, as well as fear and distrust and cultural disconnection. Lack of empathy and othering of migrant communities can certainly have a role. And then we look larger at the community level. Inadequate crisis communication, which we saw especially during this past 2 years with the COVID pandemic, cultural disconnect around social and community norms, inequitable access to social safety net services and resources, as well as migrant communities living in multi-generational crowded housing with limited employment opportunities. These all further compounded concerns around chronic stress. And then at the larger population and societal level, ongoing structural racism and anti-immigration policies and rhetoric, and some of the policies that have been culturally and linguistically incongruent, limits in insurance coverage, limits in expansion of Medicaid, especially states such as Texas and Georgia and Florida, which did not expand the Affordable Care Act, which further increased the vulnerability to migrant communities. And so you can see over the life course, you can have this a weathering effect that can take place, looking at all these layers of that onion from an individual up to the society level, upstream and downstream, that can have a profound impact on the health and well-being of migrant communities, especially refugee women and children. And so this really brings to bear an understanding of the social determinants of health. And what we see from the evidence is that health and healthcare use is strongly associated with the cumulative burden of the social determinants of health, basically where we are born, live, work, learn, play, eat, and worship, and where we access healthcare. And so this manifests in, again, racism and discrimination and violence, access to safe housing and transportation in one's neighborhood, educational and job opportunities, and income potential, access to nutritious foods and physical activity, polluted air and water, and what we also see from migrant communities, profound challenges in language and literacy skills. And so we also have to think about intersectionalities in terms of the overlapping and intersecting social identities and related systems of oppression and domination and discrimination that can also play an important role in how we think about the experiences of migrant populations, as well as particularly refugee women and children, in terms of one's own sexuality, gender, ethnicity, class, race, education, religion, age, and the list goes on, and especially one's migratory journey and pathway, as really being an important framework to think about how we can begin to advance maternal health equity for vulnerable populations. And so this really brings to bear gaps in respectful maternity care. We see, and the evidence is replete, and a lot of my work has been anchored in understanding and unpacking community perspectives that impact respectful maternity care in terms of women's distrust of the healthcare system, fear of intervention, necessary obstetric intervention, stigmatization, delay in care seeking and refusal of care. All of these compound to lead to adverse maternal health outcomes. On the provider side, we see that providers often are ill-equipped and lack clinical skills and have limited cultural competency in serving the needs of vulnerable and marginalized, including migrant communities, and often are unable to recognize their unique care needs. So what are some local solutions that can begin to address these myriad health inequities? Well, in 2008, I had the opportunity to move here to Phoenix, Arizona to start the Refugee Women's Health Clinic, which is the first clinic of its kind in the state of Arizona, and we've become nationally recognized as a best practice model advancing maternal health equity for women, and now expanding to children and entire families. And what you see represented is our team of cultural health navigators, who really are the bedrock of the work that we do and the services that we've been able to provide over the past 14 years. And so we are a patient-centered, community-driven clinic, really offering culturally grounded, linguistically appropriate services for the growing migrant communities here in the Valley. And of course, we have been serving newly arrived Afghans in recent months as well. And so we're anchored in three major core areas of focus: being locally accessible and globally minded, helping refugee women navigate the healthcare system, seeking to overcome barriers to care, and providing culturally sensitive healthcare to this community, as well as seeking to empower women and eliminating the myths and perceptions and barriers to care to optimize their health. And so we provide the full breadth of reproductive health services for women across the life course, including care for women who have experienced female genital mutilation and cutting, and integrate trauma-informed care. Through our team of cultural health navigators, we are engaged in intensive care coordination to really address some of the structural barriers to care in terms of transportation, insurance coverage, referrals for subspecialty and social service care and resources. And then we are very much embedded in the community to help lift community capacity, but also engage in community-based research to nurture and sustain trust and advance health literacy and empowerment for women. And so we serve women from over 65 countries across sub-Saharan Africa, Southeast Asia, and the Middle East. Our largest populations have been from Iraq, Myanmar or Burma, and a growing number from Central Africa, the Democratic Republic of Congo. And of course, as we have seen in the past year, a large number of Afghan new arrivals have also arrived at our doors. And through our team of cultural health navigators, they're able to speak fluently and are certified interpreters speaking well over 18 languages, just a few of them are represented here on the slide. But this really speaks to the ability for the team to listen to speak and meet the needs in the cultural and linguistic issues of the area.
Crista, I'm sorry to interrupt. It sounds like you're underwater. I don't know what's going on. We can't hear you now at all. Nothing. It's breaking up.
Mm-hmm.
There we go. Maybe it just needed a minute.
Yeah, sorry,
There
it
you
might be my internet connection. Sorry about that. Okay. Well, let me know if you have any connection concerns. Again, maybe I'll turn off my video. This might help with the bandwidth. Is that better? Turning off my video?
Right now the sound is great. So
okay,
let's
perfect. All right, well, let's move along. Okay. And so I just wanted to also highlight the central role of our cultural health navigators in really facilitating the linkages to care for our patient population in terms of,
can you put my blanket on?
Facilitating referrals to mental health care, transportation, and subspecialty services. And also we are at other sites with our Afghan new arrivals. We are located in one of our family health centers, specifically serving and providing linguistically inclusive care for our Afghans. And we also have our main campus at the hospital, as well as another site in the West Valley. And we've been able to expand to not only go beyond women's health, but pediatrics and primary care, namely family and internal medicine, providing holistic family-centered care for the entire family. Over the past 14 years, we've now served over 16,000 patients, and we are seeking to strengthen our linkages with behavioral health and providing trauma-informed care. And one of the main key anchors that really keeps us embedded within the community is our Refugee Women's Health Community Advisory Coalition, which is comprised of over 60 stakeholders across the refugee community who are serving the community in various ways, whether it's grassroots, ethnic community-based organizations, the State Refugee Resettlement Program Office, refugee resettlement agencies, the Public Health Department, faith-based organizations, and other community and social services. They inform and direct our programmatic operations and our clinical care delivery and research enterprise. And they're anchored around empowering, mentoring, connecting, and reshaping the lives of refugee women and their families. And this is a picture of from our earlier days, now going back well over a decade of our team. And we have quarterly meetings every 3 months that really helps us stay connected to the priorities and needs and remain responsive to those needs as voiced by the community. This is just a display of how we've been addressing the social determinants of health in terms of increasing access to care, advancing health literacy, examining ways to bolster safety and social interactions, as well as integrating trauma-informed care. And one thing that I'm really proud about is our work advancing maternal health equity through a value-based care pilot initiative that we've had with Mercy Care over the past few years. They were noticing that we were clearly an outlier in terms of looking at the pool of claimants that they insure, in terms of examining ways that we were improving quality metrics in our reproductive and health outcomes for our women. And so over the past 2 years, they have piloted a value-based care initiative that has funded our cultural health navigators to help facilitate linkages to care and trust that has resulted in reduced emergency room visits, reduced hospital admissions and readmissions. We have lowered low birth weight infants and have increased the timely initiation of prenatal care, resulting in cost savings in the tens of thousands of dollars just from our pilot initiative to the health plan. And so really this is a promising model for potential scalability to expand beyond women's services to pediatrics and primary care, and to be able to longitudinally examine maternal and child outcomes and really look at the critical role of community health workers through our Navigator program to really enhance quality care and cost savings for this population. And then with this COVID-19 pandemic, we've done quite a bit to really be at the front lines of really advancing the challenges and addressing the vulnerability of our refugee population during this pandemic. Our hospital was one of the first hospitals to implement universal testing for COVID-19 on our labor and delivery unit during the early months of the pandemic. And we initially saw an immediate disparity in refugees screened positive. It was 27% in the early weeks of the pandemic compared to only 3%. And this allowed us to flag the public health department to examine practices that would increase the ability for us to get boots on the ground into these communities to address community transmission. And what we've learned is that the disparity of conditions that this pandemic emerged resulted in a syndemic of COVID-19 clustering with social determinants of health to really result in adverse interactions, resulting in the vulnerabilities that we saw within the refugee community in terms of maternal morbidity and mortality and adverse perinatal outcomes. And what we began to unpack very early on in the pandemic was that in these communities, there were multi-generational households that were cramped and living together and unable to isolate. Often families were working in employment conditions where there wasn't sufficient social distancing, inadequate PPE, or even paid sick leave. There was often a denial or refusal to disclose symptoms for fear of losing one's job, which resulted in delays in screening. And of course, as you can imagine, enormous language and communication barriers and health literacy challenges, which made it very difficult to carry out successful contact tracing, especially with those efforts were initially transmitted in only English and Spanish without considering all of the other refugee languages. And so we were at the front line to really advocate for a change in some of these practices to really make sure that we were not leaving the refugee community behind. And so one of the things that our team was at the forefront of was developing health informational videos. And we developed 3 series of videos across 12 languages to help convey concerns around COVID, how to stay safe, and how to encourage a vaccine uptake in this population. And we had a massive social media campaign where we garnered well over 267,000 views during the course of this pandemic. And really at the core of this work was the trusted messengers through our team of cultural health navigators who were so key to helping us advance equity in vaccine uptake in this population, which now resulted in higher vaccine uptake in this population compared to other populations served at our hospital. And so we see from the literature that addressing vaccine hesitancy in minoritized community requires these multidimensional interventions in terms of addressing access barriers to care, engaging community leaders and trusted messengers, customizing how we communicate with the community in linguistically appropriate ways and modalities, and really leveraging collaborations with other resources and entities to advance a vaccine uptake. So let's look at some future directives. One thing that is really important to really consider is that when we think about advancing maternal health equity, we need to think about the challenges and vulnerabilities to refugee women and their families. And when you see reflected on the slide on the left-hand side, equality clearly leads out certain populations who remain unable to access appropriate care and optimize their health. Whereas equity provides support and infrastructure and services that really enable those most vulnerable to access the care and attain the highest level of health that they can receive. But what we find that in reality, populations remain excluded, and particularly vulnerable, underserved, marginalized, historically oppressed populations, including migrant populations. And so what we really want to seek to do is to break down those walls and barriers to care to really enhance the care for all. And if you can target those vulnerabilities, those populations most at risk, we can enhance the care of all people. And so what's the way to do this? Fundamentally, we must acknowledge that health is a fundamental human right. The World Health Organization Director General, Dr. Tedros Ghebreyesus, states the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. So what does this mean? Everyone should have access to the health services they need. No one should get sick and die because they are poor or unable to access services. Everyone should have access to safe drinking water, sanitation, nutritious food, adequate housing, education, and safe working conditions. They should have autonomy to control their own health and their bodies, free from coercion and free from violence and discrimination. Everyone has a right to privacy and should be treated with respect and dignity, and should not be subjected to medical experimentation, forced medical examination, or treatment without informed consent. And so what are strategies to advance maternal health equity and close the gaps in disparities when we think about intervention and research? Going back to those layers of an onion again, we really need to consider the multiple layers and factors from the individual level, the family, friends, and social support, the organization and provider level, and finally, the societal policy and community level. And so when you think about interventions, at the core individual level, we need to focus on patient care and education and address some of those biological and socio-demographic and psychological factors that can inform their health. Looking at the larger family and social network, look at how we can bolster some of the social support and safety nets for our patients and their families. When you think about the organizational level, look at how we can create innovative programs that support our migrant community in terms of improving access to care, insurance affordability, provider and system level supports. And also we have to think about the patient experience in terms of what is the organizational commitment to serve this population in terms of providing the necessary resources and supporting a climate of inclusive excellence to support the needs of vulnerable communities. And then of course, at the neighborhood and societal level, making sure that we can bolster our relationships and referral networks across the community and with other stakeholders working and serving refugee populations. And so what we really find is that these entities must interact in a way that is interdisciplinary and cohesive and patient-centered to really inform best outcomes. And this is anchored in, again, the centrality of community health workers, peer navigators playing such a critical role in that interaction to really advance improved clinical outcomes, reduce avoidable hospital admissions, improve the patient's experience with care, and expand equity in access and receipt of services, and ultimately reduce the cost of care. And so part of that necessitates that we put emphasis on how we train our leaders, train our providers, train our colleagues in cultural competency, which is anchored in anti-racism and recognition of the role implicit bias and microaggressions play, especially given our current geopolitical climate. We have to adopt anti-racist frameworks that are culturally inclusive and linguistically responsive. And it must start not just at the individual level, but also in terms of relationally, interpersonally, as well as at the institutional level. And as I have elaborated on, the importance of recognizing the social determinants of health and how this plays such a critical role in understanding access and experiences with care for vulnerable populations. And this requires iterative training at all levels, from trainees and administrative staff and leaders to even the front desk staff who meet our patients upon registration when they first enter in the health facility. And these trainings must provide opportunities for social safety.
Crista, you're all muffled again.
So sorry, I've had these communication challenges this morning. Is that better?
There's a little bit of an echo. Can you talk again?
Can you hear me now?
Yes, that's clear.
Okay, I'll try not to move. So, and when you think about the training, it should provide opportunities for self-reflection, for one to consider power hierarchies along culture, race, and gender. It should seek to challenge one's own assumptions and stereotypes while avoiding othering minoritized communities, and seek to think about how we are engaging with our patients, and not just the words that we say, but nonverbal communication, our body stance, and how we infuse trauma-informed and patient-centered approaches to care. These trainings should also exist as enduring learning materials online, and we should seek to cultivate safe spaces for both providers and patients to report encounters with care that may have been untoward, but also really seek to cultivate cultures of inclusive excellence. One thing that is really important for us to recognize is that we are woefully behind and not made significant advances to how we recruit medical students of color. When you look at this slide, going back now over 40 years, we still remain grossly underrepresented in medicine. When we think about communities of color often receive better quality care when served by providers of color. When you look at what has happened in the last 40 years, you clearly see that for Black and African-American students, we have not made any improvement in recruitment and matriculation of students into medical school. We have similarly for Hispanic and Latinx students not made much improvement at all. And what's even worse is for American Indian, Alaska Native students, it's pretty much remained zero, flatline in over 40 years, and only marginal improvement for Asian American students. And this is something that we must tackle, especially as we are thinking about addressing health equity for migrant communities, that we need to think about recruitment and retention that will bring in the expertise of migrant populations that have extraordinary backgrounds, who may have been working in health professions in their country of origin before displacement. And oftentimes the trajectory to medical school and residency can be very challenging for migrants. And how can we support programs that can help in bringing these individuals in terms of supporting workforce development, to provide pipeline opportunities, not only for themselves, but their children, especially those that have been living in this country for a long time. We need to think about how we can nurture these programs to start from the elementary school level and not wait until the postdoctoral level and graduate school level to focus on the recruitment and retention and promotion, not only of diverse faculty who will serve as those mentors, but on the trainees themselves. And I can't emphasize that enough in terms of looking at our professional societies, whether it's through national refugee health service providers or other professional networks that can support diversity, equity, and inclusion efforts to really harness some of the expertise that exists among migrant populations that are now living within this country, and provide leadership opportunities and provide workforce development and integration that can support the growth of peer navigators, such as what we have at our team at our hospital, but also other maternal child health champions and innovative platforms and modalities to increase representation and a focus on diversity, equity, and inclusion as so critical to advancing maternal and child health equity. Also, another critical point is how we engage with our communities. Community-based participatory research has been recognized as so critical in terms of really building and nurturing and sustaining trust with historically marginalized communities. When you think about refugee populations, they have survived enormous human rights atrocities. And women in particularly have been exposed to gender-based violence, whether it's early child marriage, rape as a weapon of war, intimate partner violence, human trafficking. And we have to think about how these vulnerabilities impact populations' willingness to retell their story or even engage in research. And we have to think about larger gender inequities in terms of women's access to education and women's empowerment, and really seek to promote equitable, trust-based community partnerships that can employ community advisory boards to serve as local champions, ensure accountability, and make sure that we're engaging in bi-directional educational outreach and capacity building, that communities are involved throughout all phases of the research, including the dissemination phase, and that we are cultivating and nurturing safe spaces for that bi-directional dialogue, and making sure that your team represents the community that we're serving, and making sure that we are bringing on board the faculty and trainees who represent the target communities most vulnerable, and seeking to nurture partnerships with our public health agencies, other public-private relationships, and other multi-center collaborations, which are so critical to nurturing these safe spaces of community embeddedness and trust. And then in terms of data, research, monitoring, and evaluation, it is so critical to make sure that we can advance data equity. It's not enough to just disaggregate data based on race and ethnicity, because particularly for refugee communities, they do not fall under those neat racial and ethnic categorizations. We need to add greater specificity by considering language, country of origin, ethnocultural specificity, geospatial residential clustering, and make sure that validated instruments have achieved cross-cultural and linguistic equivalency. And nowadays, we're hearing a lot of discussion around precision population health. We need to think about, as we develop algorithms using artificial intelligence and machine learning, that we are not perpetuating bias, ingrained bias in how we think about and look at data. When we think about how we optimize patient care, we have to make sure that we are not leaving out refugee and other migrant communities, and making sure that they are represented in clinical trials and provided opportunities for receiving pharmacologic and psychologic interventions. And part of that, in order to make that happen, we need to make sure that we put patient registries in place. We finally have a refugee registry that was established last summer that comprises over 16,000 of our patients. And now we can use and harness the power of this registry to examine preventive health outcomes, chronic disease management, and maternal child outcomes, and look longitudinally across the reproductive life course. And that can help inform how we develop patient safety bundles and also examine the patient experience. And that is so critical to informing respectful maternity care, to make sure that the language that we use, our approach to our patients, are non-stigmatizing, are respectful, validating, and cultivate these safe spaces. I mentioned also value-based care models as an innovative model of how we are advancing maternity care financing. And one thing that our hospital is seeking to do more of is really integrating trauma-informed care to make sure that we can co-locate and integrate behavioral health promptly for our new arrivals, and to get them plugged into not only our primary care, pediatric, and women's health services, but make sure that we're addressing the emotional needs for our patients as well. And then, as we see, was so critical for the COVID pandemic is messaging, and who is the messenger and how we are conveying that message to the community. It must be tailored and culturally and linguistically responsive to refugee communities. And finally, we do know that health literacy persists as a major barrier to care, only made worse because of the pandemic, because of the switch to telehealth. And so we have to think about addressing the digital divide in terms of how can we infuse image-based health literacy mobile applications to enhance patient understanding and enhance patient communication and education. And on top of all of this, as I cannot overemphasize enough, really making sure that we infuse attention to the social determinants of health, whether it's the healthy migrant paradox and how that might shift depending on migratory pathways and length of time displaced in secondary countries. We know that the healthy migrant paradox that we've seen for Latinx communities may not apply to other refugee populations. And we have to also think about epigenetics and how we can look at transgenerational maternal stressors and how that influences epigenetic memory and one's lifelong exposure to racism and discrimination and bias, and how that produces a weathering of chronic toxic stress on the lives of women. And so it's very common to think just about the human rights atrocity and vulnerability and victimization of our population. But I like to take a different approach in terms of looking at an asset-based strength approach, where we think about the cultural vibrancy and strength and endurance and resilience of our refugee community, and build on that to nurture and sustain trust. And that is so critical because there's so much of the cultural resilience that really can be harnessed to improve innovative strategies to advance health equity. And it can inform how we nurture and create safe spaces of mutual respect and unity and empathy. We communicate with our population and how they have autonomy in decision-making that affects their body.
Crista, sorry to interrupt. You're sounding really far away and muffled again. We can't hear you. No, not at all. No, can't hear. Nope.
Krista, we don't hear any sound. We're just reading your closed captioning.
Yeah. No, we can't hear any audio now.
Thanks all for your patience. Hopefully this will be just a short little delay.
In the meantime, if folks have questions that they want to ask, go ahead and put them in the chat, because we're moving towards the end of the session, and I'd love to be able to get those questions to her when she logs back on.
Can you hear me now?
Yes, we can.
Okay. So sorry about the connection issues this morning. I'm literally on my last slide. Thank you for bearing with me. Okay. All right, can you hear me now?
Yes.
Okay, let me just get through this last slide. Okay, so sorry. I sincerely apologize for my connection issues. And so just in closing, I just wanted to talk about the important role of advocacy in really seeking to empower and advance equity for refugee communities, especially refugee moms and children. You know, silence and complicity are not options. We really want to foster cultural humility, recognizing our collective global humanity, and for all of us to use our power, privilege, influence, and access to dismantle inequities. And this requires us to step outside of our comfort zone. And it really pushes us to speak up for the voiceless and disempowered and speak truth to power when we're encountering instances of bias and prejudice and microaggressions, working with our populations and our communities, and really advocate for the lived experience of those who have daily experience of bias and racism in healthcare. And really, we should use our influence and power to name, acknowledge, and dismantle systemic and structural inequities that perpetuate disadvantage. And we should also empower our patients to be able to seek out gender, racially, ethnically, culturally, and linguistically congruent care, and really normalize patients' own self-advocacy and questioning clinicians' practices, and really seek to nurture safe and inclusive environments. And I really want to really emphasize the importance of nurturing trust and radical empathy, because radical empathy is about becoming aware of the lived experience of others, not through your lens, but through theirs. And it is about acknowledging that your own perspective colors the way you evaluate others' experiences. And it really takes a community for all of us working together in our spaces and spheres of influence, whether it's at the academic level, community-based organizations with local government, social service entities, how we engage with the media and healthcare institutions, even faith-based institutions, that it's really it really takes a village to inform quality, culturally informed, linguistically infused care for the most vulnerable populations, particularly migrant and refugee women and children. So I want to thank you for this opportunity to present before you today. I'm so sorry for the audio glitches. and my bandwidth challenges, but I hope this has been insightful and provided important perspectives that inform how we can advance maternal health equity, but really taking the world's global challenges and really applying some innovative and novel approaches at the local level and regional level to really impact the communities in which we interface with on a daily basis. So thank you so much for your time, and I appreciate you bearing with me through my audio challenges today. Thank you.
Thank you so much, Crista. It's always such a pleasure to learn about your work. And I think we have time for 1 or 2 questions. And we do have a question that showed up in the chat a little bit earlier. It's a really great one, and I think aligns with the last few slides that you presented. So Jasmine Mark has asked if there's a list of or website where they could go to see the locations that they might be able to volunteer in supporting refugee populations in the local area.
Yes, I could probably connect you with Juliana Davis, who is our state refugee health coordinator, as well as the state refugee resettlement program office, because there are a number of ways for us to be engaged, and those who are interested in serving and working with refugee communities. There are myriad ways from not just the health sector, but what incredible work being done in the communities through the resettlement agencies, ethnic community-based organizations. There are myriad different ways to engage with these populations, and I could probably connect you all to Juliana Davis, as well as the state refugee program office, and I could probably put a link in the chat perhaps, or maybe it could be disseminated after the conference for those who are interested.